So I'm Jeff Cleaver, the Executive Director of the Business Healthcare Group, and I'd like to welcome all of you to our 7th Delivering Value Series Symposium of 2022. And I would also like to thank all of you for taking time out of your very busy days to be with us this morning. And a special thank you to our presenters and panelists this morning for the sacrifices that they've made to join us. And there we have attendees both in person and virtually. And we will be taking questions for the panel from individuals within the room, and then there's a question box on your screen, and if you have questions, you can just type those questions into the question box. And we are truly looking to have a very engaging discussion this morning and really look at it as an opportunity to have your voice heard with Rivka and Lisa and Bernie and Todd Smazel from Northwestern Mutual. And I think it's truly an incredible opportunity for all of us with the stellar presenters and panelists that we have with us this morning. So I'd like to go over the agenda for this morning. So opening remarks from myself, then Todd Smazel, who's the Vice President of Total Rewards and Talent for Northwestern Mutual, is going to provide a BHCG C-suite perspective on employers as agents of change. And then we will then move to Rivka Friedman, Head of Healthcare Innovation, Morgan Health. And Rivka and Lisa will actually, and Bernie will actually give you a short bio introduction also. And then we will then move for alignment and accountability, provider community perspective with Lisa Belmakowski. I blew it. Dolomovich, thank you. And I practiced. And then we'll move to how to prepare for the new world. The Wisconsin Health System Perspective, Bernie Sherry, CEO of Ascension Wisconsin. And then Dave Ostendorf, who many of you know, who is a strategic consultant for the Business Healthcare Group and also the Chief Actuary for Centivo. We'll speak to the BHCG Centivo model, a win-win for providers, employers, and employees. And then we will transition to the panel discussion. So with that, Todd?
Good morning, everyone. Jeff, thank you for allowing me a couple minutes up here, but also for putting this morning together. For the employers in this audience, I think that the theme of this morning is really important. We all need to take note of the role and the responsibility that we as employers have in initiating and driving change in healthcare. And while it certainly is not easy and sometimes it's thankless, it is terribly important to our members. And when it gets difficult and you question if you want to continue to sink in your teeth on this issue, I think it's easy to just take a step back and think of all of the members that you have responsibility for in providing healthcare solutions to, and the challenges that they face by way of both quality and affordability of healthcare. And that's where we as Northwestern Mutual stand and recognize and believe that we can't sit on the sidelines and wait or hope for a solution. We have to be part of that solution. And For the employers in the audience, I think one of the first steps that we took, and this is probably 15 years ago, and we've been at this for a while, but it was to be a part of the Business Healthcare Group and to work with our fellow employers in southeastern Wisconsin and in this community to think about and initiate how can we influence better healthcare by way of cost and quality. And I don't want to spend a lot of time up here this morning because I did have the opportunity to hear from several of our other presenters last night, and I'm quite confident that their insights will be far more valuable to you than my insights. But I just want to reinforce the theme of this morning and the responsibility that we as employers in this community have to not only the employees in our organizations, but the citizens and the lives that are in this community and influencing how we can make sure that we have the best healthcare in southeastern Wisconsin in comparison to many other metropolitan areas. And I appreciate the partnerships that are being formed as we speak in recent years between employers, the health systems, Centivo's partnership in this. I think we are on the verge of making some tremendous breakthroughs, and we see it already in some of the experience of our members. So Northwestern Mutual decided last year for plan year 2022 to step in and to participate with the Centivo network. And as an administrator, we were fortunate to pick up about 35% of the lives in the markets that Centivo kind of has available solutions in. And we're making great progress, and they've been a tremendous partner to us in making sure our employees understand kind of the value proposition that we're positioning. So with that, I appreciate the time this morning and look forward to ongoing discussion and conversation around how we can drive change in our community. So thank you.
Good morning. Can you all hear me okay? So my name is Rivka Friedman, and I lead the Healthcare Innovation Team at Morgan Health. And this morning, before we get into our discussion, I want to share a little bit about what Morgan Health is and the role that we are playing, both for JP Morgan Chase, where we're seated, and for the sector writ large. So some of you may know about something called Haven, which was a joint venture between JP Morgan Chase, Amazon, and Berkshire Hathaway that launched 3.5 years ago, roughly, and then folded shortly before COVID or during COVID. In the wake of Haven winding down, JP Morgan Chase decided to go it alone with Jamie Dimon, our CEO, really in a leadership position saying, we have to really take a step both back and forward here, observe what it is that we are doing as a very large employer, buying healthcare for our employees and their dependents, and then take a step forward and really lean into that responsibility to drive change. For context, JP Morgan Chase spends $2 billion a year on healthcare. So it's a staggering figure. It's a staggering figure even in context of a multi-trillion-dollar balance sheet that we have, but a staggering figure nonetheless, and I think really the catalyst for our leaning in here on healthcare. So Morgan Health is a wholly owned business unit within JP Morgan Chase, and you can see here our mission statement, which explicitly focuses on both JP Morgan Chase's employees and dependents and on the sector writ large. We are charged with improving the quality, equity, and affordability of healthcare for both our employees and dependents and employees and their dependents across the country. And we are doing that in two main ways. The first is as a strategic investor. So we have a ventures team within Morgan Health that makes strategic investments in promising healthcare companies that are focused on the employer sector and uses those investments and the support that we provide as a strategic investor to really push those companies forward. We have invested in Centivo. So Centivo is one of our portfolio companies, and look forward to talking today about why we invested in Centivo, the role that we see them playing in the sector, and what we hope they and potentially other companies can do to really evolve the sector. So that's one. Two is the healthcare innovation team, which I lead, which is charged with launching pilots in innovative healthcare delivery and payment solutions that we can test with our own employees and their dependents and then scale across the sector. And there too, we're focused on quality, equity, affordability. So this theme of quality, equity, affordability runs across both areas of our business. So the main question that I want to try to answer before we get into our discussion, and hopefully this will be fodder for the discussion to follow, is why employers and what is employers' role? What should employers' role be? I do think this is a double-edged sword. And I said this last night, that, bearing the cost and the responsibility of structuring healthcare for employees and dependents is probably not something that most employers would do if they had the choice today. It's our cross to bear. And it is the way that our system is structured, at least until Optum gobbles us up and makes a single payer system. So for the time being, we have a responsibility to drive value in the healthcare that we are essentially purchasing for our employees and dependents, right? And most of us as employers are purchasing the majority of that healthcare. Our employees and their dependents are buying maybe 20%, right? And we are shouldering the other 80, roughly. So this is how we think about the theory of change, the role that employers play in healthcare. First, vis-a-vis our members, our plan members, right? Our employees, their dependents. We have a responsibility to drive consumerism for our employees and their dependents by sharing better information about what they're buying, how much it costs, and whether there's value in what they're buying. We have a responsibility to take that consumerism and translate it into better shopping for healthcare. And some of that is our relationship to our employees and their dependents, but some of it is our relationships to the providers that are in the networks that we offer. And of course, by dint of those relationships, our relationships with carriers who are structuring and administering those networks. We have many tools at our disposal to drive better value in the networks that our carriers create and that our patients ultimately use. We think about those in two areas, at least for today. The first is in access to better primary care. So you'll hear this in our discussion, but we have made strategic investments in advanced primary care companies, most notably Vera Whole Health, which is an advanced primary care company that we are deploying for our Columbus employees. And then separately, but related, in value-based specialty care, right? So primary care being the first tool. Second tool is when somebody has to go to a specialist, how do we make sure they're going to a good specialist, an affordable specialist, a specialist that is well connected into primary care? We're really thinking about an ecosystem that we're trying to create. And I think we'll have a chance to talk about the role that carriers play in creating and then perpetuating that ecosystem. But that's a key role as well. And then lastly, we have a responsibility to build incentives into those networks so that we are paying physicians, providers, and those who are administering these networks for value creation. And again, we define value as quality, equity, and affordability. So we are looking for better health outcomes for care. We are looking to close disparities by race, by income, by geography, and other categories. And we are looking to drive affordability for our employees and their dependents, and by extension, the sector. Quickly, just to hit on this, we are thinking about quality and equity at a very high level. We believe that health outcomes are part of our responsibility. We are also thinking about it very granularly. So you can see below here some examples of measures that we are thinking about that we are going to put into every contract that we sign. Part of our job is to create some consistency in expectations so that if you are working with JPMorgan Chase, if you are working with Morgan Health, there is an understanding that you are focused on key outcomes that we have identified as prevalent in our population. And then I think this is my last slide. The enablers for this system are proliferate. There are so many companies that are focused on data that can fuel provider networks, that can fuel carriers and their approaches, that can even help employers directly create consumerism and such. And we are spending a lot of our time looking at these data and tools and trying to identify what are the key ingredients that make these tools good. How can all of the stakeholders in the healthcare industry leverage these tools for better? And then what is our role in bringing these tools into the system in ways that actually improve the consumerism, the behavior of our employees, their dependents, carriers, providers, and others that we work with. So looking forward to talking about this piece in particular, because I think it's a key and maybe underestimated piece of Centivo's strategy, but also just an absolutely essential ingredient in the networks that we are all trying to build to drive better value creation in healthcare. With that, I will hand things over to Lisa. Hopefully my little light microphone will work. Can y'all hear me in the back? Awesome. Well, thank you, Rivka. And my name is Lisa Vilimovich, and I am the president and co-founder of a small DC-based advisory firm called GIST Healthcare. We work primarily with hospitals, health systems, and large physician groups to help them think about the future and to drive change. If you're curious as to why we called the company GIST, it's what we hope to do anytime we get a chance to be with folks like you, is to take all of the complex and sometimes seemingly conflicting market forces that are in front of us in this crazy industry. You know, policy pulls us in this direction. There's tons of disruption going on. We had a pandemic come out from the sky, something that, I've been doing work like this for 20 years now, and I don't think I ever said the word pandemic in talking about the future before 2020. So unexpected things can happen, but we try to put all of those things together and give you the gist of what matters so that you can think about your strategy for your employees, your company, and others, and try and prepare for the future. What I want to do in the few minutes I have with you is to give you an idea of how the provider community is thinking and operating right now with a double click on where they are with value. You can see my little title here, Confronting a New Economic Reality. I think hospitals and health systems in particular, and Bernie will be able to give you the on-the-ground perspective here in Wisconsin, are potentially in the toughest place that we have seen, at least in my 20 years of doing this. All of you are having challenges with labor, with recruitment, with rising costs. It's really amplified in healthcare. And, we've talked about value and payment change and all these new care models, moving the system. I actually think on the provider side, the tough place where we are economically might end up forcing more change than any kind of payment policies that are going to come down from Washington or United Healthcare or anyone else. So let's talk about the history of value. Where have we been? Put together a little postcard from 10 years ago. If you think where the zeitgeist was in 2012, remember we had just passed the Affordable Care Act. There was a ton of optimism that the whole market, led by the legislation, which largely put the shift to value in the hands of providers, doctors and hospitals, was going to transition to value-based care. So optimistic that you would hear pundits out there say things like, we're going to get so good at managing care, we're going to be paid in a different way, we're never going to need another hospital bed. Stop building hospitals. We're going to organize doctors into these integrated networks that are going to focus on value, and the contracts will come. For you employers, 10 years ago, we were saying, maybe there will be a path for you to get out of the provision of health benefits. The exchanges are going to take off, both Obamacare and private exchanges, and you're going to move to defined contributions. You have your employees a lump sum of money to benefit, and this is going to be fueled by all the information and data that we'll have at our fingertips, because the feds had just spent something like $30 billion to wire the entire system, put electronic health records in every provider's office, in every hospital. And so data is going to be ubiquitous, and we'll be able to use it to make better choices. And oh yeah, even though, 2012, we were just coming out of a recession, healthcare is recession proof. No matter how bad the economy gets, people are still going to get sick. They're still going to need care. And so at least on the provider side of the industry, we'll be able to weather anything that's in front of us. Well, fast forward to today, and I think we have 100% proven that healthcare is not recession proof, and that the provider side of the industry is feeling the economy in a way that we never would have expected. What I've got here are 5 forces that if I am running a health system right now, these are things that coming out of COVID have just accelerated in impact on my business. If I think at the very highest level, what did the pandemic do to healthcare strategy? It didn't change a lot of things. There's not much that I would say, in 2019, we were doing this. Now I need to take a complete 180 and do something totally different. What it did was accelerated changes that were already happening. The case in point that I think is obvious to most of us is think about telemedicine. Prior to the pandemic, it was rare for you to even think about, could I do a video visit with my doc? Well, in March of 2020, primarily health systems
took 5-year digital strategy plans that have been sitting on a shelf and figured out how to implement those things in the span of 3 weeks so that all of us could be connected to the care that we needed as much as possible when it seemed very scary to go anywhere, much less a hospital or a doctor's office where in our minds we're like, wow, if I go and I sit there, I'm around sick people, and definitely in COVID, I don't want to be doing that. That's a perfect example of something that accelerated. These are also things that accelerated. You know, I think we got a bit of a reprieve with the economy in 20 and 21. We would have thought it would get worse earlier, but then coming out of the pandemic, now we're teetering on the verge of recession, which has made the labor market really tight. You know, for the average health system, I'd estimate labor costs have gone up about 20%. And I think even more than the money that you have to pay to get the talent that you need, it's just that there aren't the bodies out there, particularly in key areas of the workforce like nursing. Demand has also changed. And I'll show you some numbers if you're thinking about, wow, did all of that telemedicine and the ways that people were accessing care across the past 3 years change where people are going to go for healthcare? We're finally at a point where we can say, you know what, there's probably some secular or permanent changes that we should be thinking about for our employees and others as to what they're going to want from healthcare based on what we've all been through. And I think the last and something that's super important as we think about the healthcare marketplace is that disruption, again, something we've been talking about forever, that, you know, Walmart or Amazon or big insurers are going to make bigger and different plays in healthcare. That has just lit like wildfire the past few years. Why is that? You know, your health system and physician colleagues will tell you that they were really, really impacted in the first couple of years of the pandemic because volume went away. People were scared to come in, they were delivering less care. Well, if I'm an insurer, what does that mean? I was still getting premiums from you, but I was pocketing all that coin, and I could use it to buy a whole bunch of different assets across the care continuum. If I'm Walmart, people were scared to go to see their doctor, but they never stopped milling around Walmart on the weekends. Their business did really well. So a lot of those companies were very fueled to make moves that, you know, they had started to do, but now in the wake of COVID are betting big on healthcare. So I'm just going to give you a little bit of an idea about how all this is playing out and the impact that it is having on the move to value and how employer-based healthcare options are changing. You know, there's no doubt that, you know, any of us who go to the gas station and fill up our cars knows that we're in the middle of an inflationary environment. Half of the country was not born in 1980, so for most of them, this is the worst recession they've ever experienced in their lives. Big important thing on the right, look at where consumer confidence is. That top graph, it's just trended down. 4 out of the top 7 things, if you ask consumers what they're concerned about affording, are healthcare. Why is this so important now? Because we have made healthcare a consumer good over the past 10 years, largely through the march of high deductibles. You know, if you look at the average deductible out there for an individual, it's $1,700, $3,200 for a family. That's a lot of money coming out of pocket if I have a significant care need, particularly given that somewhere in the neighborhood of 2/3 of Americans have less than a couple of $1,000s of cash in the bank. So, you know, from their perspective, they are self-funded. They can't pay that bill. And that is having a big impact on health system margins. You know, whether you're a big system or a small standalone hospital, the fact that demand has gone soft, consumers are having trouble paying their bills, and I'm having to pay way more on labor than I ever anticipated. You probably have heard of contract nurses, agency nurses, health systems having to go and hire those travelers, which can cost 3 times more than having a nurse on staff. It's just made expenses go through the roof. And I don't think this is connected to COVID anymore. You know, it's not the pandemic that is driving these challenges right now. Keeping the doors open, finding the staff. I think this is something that is a, you know, maybe not permanent, but we're looking at 5 to 10 years at least of rising labor costs. And I think really important for health systems, you know, we haven't seen prices go up. And, you know, I'm not saying that payers should necessarily be paying health systems more. You know, rates don't need to go up forever necessarily, but right now doctors and hospitals are really pinched, and it's kind of been the opposite, particularly with the large national payers coming in and saying things like, you know what, let's start with a 30% price cut. And, you know, at a time when health systems are having to pay through the roof to get the people that they need in seats and to get the supplies and drugs that they need to keep things going. And that's leading to margins, as I said, just being really challenged across the board. what happens when times get tough? We saw a lot of this in the last recession we had in 2009. Smaller organizations think they need to find a bigger partner. But if you look at the margins here on the right from the nation's largest nonprofit systems, scale isn't necessarily protective. When it costs me 20% more to hire any new nurse, it doesn't matter if I'm big or small, I'm going to be impacted by it. To give you an idea of what this looks like across the country, every single health system I've talked to since early summer has said we're not meeting our budget targets, and somewhere between 50 and 60% are actually in the red. And so this is a very, very challenging time. And like I said, I think it's going to force a lot of changes. As I mentioned, we've seen changes in volume where people want to get care. The complicated graph, it kind of looks like what these different lines show is the different settings of care and how they have trended since 2020. Two that I think are important, the ones that I think are permanent changes that need to be on your radar. That top line, the orange one, is outpatient volume. As you can see, after everything cratered in the spring and summer of 2020, outpatient volumes came back really quickly. The big trend here, anything that can be done outside of a hospital is going to move there. This is something that's been happening for 30 years as technology allowed things like minimally invasive surgery. But take this number. Now, 60% of hip replacements are done in an outpatient setting. I mean, a knee replacement's a big surgery, but that's a 55-year-old guy who blew out his knee playing basketball on the weekends thinking he could still do it like he did when he was 18. A hip replacement is your 85-year-old grandmother who also has heart failure, diabetes, may not be able to take care of herself at home. And there's a good chance now if she falls and breaks her hip, that could be done in a surgery center. It is good news for payers and employers and consumers because provided you can handle that recovery, the cost that you are going to be exposed to for an outpatient procedure is half of what it would be to do an inpatient. It's bad news if you're a hospital, obviously, because you're going to have to adjust to getting paid half of what you got paid before to do that procedure in the hospital. The other line to watch is the blue one, which is emergency department volumes. Again, these have waffled, but I think one of the silver linings of COVID is that people have learned as consumers to maybe not go to the emergency room for small healthcare needs, sore throat, sniffles. There are other places to go. Telemedicine opened up new channels. These are the things that I think are permanent as far as big shifts in how we're going to receive care. Telemedicine volumes have gone down, but I think it's now an expected choice of consumers. Works better for some specialties than others. Works okay for primary care. Works really well for mental health. But it's kind of like, what's that old phrase? Once you've shown the girl Paris, she's never going to go back to the farm. Now that we've shown consumers telemedicine, they want to have that as an option in their toolbox in order to be able to receive care. Now, how has this translated into value? If there is one trend that has maybe slowed down during COVID, I think it was the progression to value. And you can see here's a state of the industry right now, and I apologize, these numbers are looking a little wonky there on the left. On the left-hand side is the government perspective on value. How have the Medicare shared savings programs trended over time? You can see compared to total Medicare spend, the amount of money, which is that they have saved, which is that blue line on the bottom, is minuscule. So over the past 10 years, we have saved 0.06% of the total Medicare budget through these accountable care programs, which is why things like Medicare Advantage, handing over the keys and the risk in the Medicare program to commercial insurers, have grown like gangbusters. Look on the right. If I'm running a physician practice or a health system, only a very small portion of my revenue is in true value. The numbers on the top are health systems. 1, 2, 3% on average. This was a survey of 300 health systems. I can show you ones that are making big bets on value and have numbers that are much bigger. But this is the national perspective. And same thing, a little bit better for physicians, but still well less than 10% of all the money that they take in getting tied to value. So you can see if those contracts aren't there, whether because they're not chasing them or because they're not being offered in the market, it's very hard to change how I do business. Now, who is changing how they do business? If there's anything that's going to impact health systems long term, it's this. This is the nation's biggest healthcare companies by revenue. The biggest health systems are the ones here in the turquoise all the way on the right. which you can see that the biggest amongst the provider community are still teeny tiny compared to Walmart, Amazon, CVS, United Healthcare. All of those companies now $350 billion plus. My United numbers are a little bit old there. You add all of the biggest health systems in the country together, and they still don't meet the size of these guys. And they are now coming in. Like I said, they've got war chests, and they are making a very different bet. You know, the one that I would watch most closely is United Healthcare through their Optum division, which is where they put their provider assets. Did you know that United is now the biggest employer of doctors in this country? They've got 65,000 now. They hope to have 100,000 sometimes next year. That's bigger than Kaiser. It's bigger than the VA. They own the second largest surgery center chain, the nation's largest urgent care center chain. Plus, they get all of your data, all of hospital and doctors' data, put that all together, combine it with their pharmacy benefits management. What they're putting together is they've got a health system without hospitals. And they're going to use that to try and catch their beneficiaries, profit from the care delivery, and hopefully make more on the insurance side. They're not doing this for you. Just know that. They are doing it because of demographics and the fact that our constituency in the insurance world, the commercial business, is actually shrinking for them as the baby boomers age. This is a complex slide, but it's a fun one. It shows the ebb and flow of different generations in our country. The downsloping teal line, and I hate to say it to all you baby boomers, you are on the downsloping line, is the baby boom generation. We're right here in 2022 right now. The biggest thing that's happening to health systems is happening to insurers, that the baby boomers are moving from their commercially insured years to their public pay years. That's totally disruptive for this business. It's why United and others are making huge bets in Medicare Advantage. They're following where the customers are going. If I'm running a hospital or health system, the big challenge I have is how do I manage the aging of the baby boomers without bankrupting my organization? Because if I take someone who was coming to me last year and had good commercial insurance and was largely coming to me for things like that knee replacement, now 10 years later, they come to us with Medicare, which hospitals tend to not make a profit on. Whether that's right or wrong is a different discussion, but where they are today, they're underwater on Medicare, and they're coming for a medical condition. The 75-year-old lady who is staying in the hospital for 4 days with a congestive heart failure exacerbation, nursing care and drugs, send her home. Same thing's going to happen. She'll be back again in 6 months with the same problem. Hospital business model can't run on that. If I'm running a health system, I have to find a way to manage the decline of the baby boom population without going out of business, because essentially what my hospital becomes is a skilled nursing facility. But waiting in the wings, we have the other generational transformation. The top two lines, the orange of the millennials and navy blue, is Generation Z, even younger. If I'm running a health system, and I would imagine as you think about your employees, it's the same thing. Not only do I have to think about, wow, the aging of the population, how am I going to manage that? I've got a completely new kind of customer waiting in the wings. Think about your average millennial, raised on Amazon, wants what they want when they want it, don't want to talk to you, would rather text, brand switch on a dime. Gen Z, probably even more so. If I'm thinking about healthcare of the future, I have two magic tricks I have to pull off. Manage the aging of the baby boomers, again, without bankrupting us, and transform the system so that when the millennials hit and start having real care needs, right now they're mostly just having babies and taking their kids to the pediatrician. That's how we know them as healthcare consumers, but they're going to be there before we know it. We think of millennials as young. The oldest millennials are in their early 40s now, and they're less healthy than their parents, more mental health, more chronic disease. So they will present to the system and to all of you on your benefits rolls with higher cost care earlier than I think we would have expected. But if I'm a health system and I want to build loyalty with those folks, I'm going to have to deliver care and engage them in a completely different way. So my last slide, I'll leave you with this. As we think about the future, we've got all of these other entities coming in and wanting to own the relationship between patient and provider of care. If I'm thinking about what they're trying to do, they're trying to make healthcare a platform business. A lot of the economy is moving to platform businesses. Amazon is a great example. The retail platform that earns your loyalty and makes you spend more. Raise your hand if you're a member of Amazon Prime. Okay, we have to ask it the other direction. Raise your hand if you're not a member of Amazon Prime. Is there anyone in this room? Wow, zero. All of you are paying $200 a year for the pleasure of spending 87% more on Amazon. You can go there and get whatever you need. Healthcare is starting to organize in the same way. Who owns the consumer? Who has the platform? There's several ways this could play out. One is something like United Healthcare owns the platform, a health system without hospitals where insurers manage that relationship. There's a free market view of the future where, potentially consumers direct their own care. I have an app for this, an app for that. Mental health, I go here. Here's my diabetes management app. I go and see my primary care physician. The problem there, is healthcare is complicated. If we can't get all of our heads around it, how are your employees going to get around it? Fragmentation has impacts that aren't necessarily good for consumers. We're hoping more and more that health systems can be at the center of that platform relationship, where they are able to bring together the resources in partnership with employers, insurers who want to work together in order to create that platform that is centered around care. So where you've got a relationship with a doctor and a health system that no matter whether you have a need big or small, you know where to go to get your problem solved. And that the goal is not just making a good margin, being successful this year. The goal, yes, we want to deliver good quality, but it's not just quality. It's a lifelong relationship and a lifelong home for a consumer's healthcare. So, if I could wave a magic wand, that's where I would want the industry to go. But with that, thank you for letting me share a few thoughts. And I will turn it over to Bernie to tell you what's actually happening in health systems.
Great to be with everyone. I think Rivka and Todd and Lisa, you nailed it. One thing she didn't mention a year ago, I'm not going to rehash all the things that are going on in healthcare because I think she actually just nailed it, right? I would just affirm that's exactly where healthcare is today, right? And that's where health systems are today. And a year ago, I didn't have gray hair, right? That's all I'm saying. That's one stat that I'm sharing with this group. I really appreciate the opportunity. I'm going to tell the story on the ground related to Essentia Wisconsin. But before I do, again, my name is Bernie Sherry. I'm the CEO of Essentia Wisconsin. I'll give you a little overview of Essentia Wisconsin, but also Ascension, right? So Ascension is in 19 states. We are a large not-for-profit, faith-based Catholic healthcare system. We have 139 hospitals and 2,600 care sites. Here in Wisconsin, we have 17 hospitals. Right? We have over 1,100 primary care and specialty providers and 100 different care sites. That really is meaningless until we get down and we talk about value. What does all that mean from a value standpoint? I want to go back because I have to tell this story. I was in Tennessee. I've been with Ascension for 22 years. I spent 16 years in our Tennessee market, and every market is different. That's the reality of healthcare today. Just the way healthcare is delivered. Every market is a little bit different. I land here in 2016, April of 2016, and probably within the first 4 or 5, 6 months, I have an opportunity to get introduced to Jeff and the business healthcare group. When I was in Tennessee, there wasn't really a business healthcare group. The employers were not really organized in a way. There wasn't this push to really come together as an employer community and drive value. So Jeff invited me to come and spend some time with the board of the business healthcare group. I was learning. I was listening. At that time, Essentia Wisconsin, 6 years ago, we were hospitals, period. Hospitals, right? That weren't positioned to meet what the purchasers of healthcare, all of you, needed. So I sat there and listened, and at that time, BHCG was working with a carrier, and at that point in time, it was the board, and I just listened. What does the board need from a healthcare system? This is important. Lisa talked about it. Rivka talked about it. The design of the healthcare system to meet, in this community, about 40% of healthcare is managed by all of you. These are your associates. These are your members. These are your employees. This is your team, right? And when I listened to the board at that point in time, it was really driven about how can we create greater value for the carrier relationship we had at that point in time. And Ascension, I went back and said, well, how many of our primary care physicians are seen as value providers? And we were sitting at 70% at that point. And historically, I think this is way before my time and maybe before Jeff's time. I'm going to get to the punchline. There were Ascension facilities cut out of a network design. And I'm going to tell you what a flaw that was at that point in time. Because you weren't looking at data, you weren't looking at where value is created and how value is created. So I made a commitment to Jeff, I made a commitment to the board that Ascension Wisconsin in this marketplace, we were going to build a network that would create value across the state in this community. And that's exactly what we did. And so over the last 6 years, we have moved from being hospital-centric and a network not paying attention to what the consumer needs when you say value. Now, what do we define as value? Right? It's a network of care delivery sites, physicians, specialists, hospitals. We also developed imaging centers. Imaging doesn't need to be done in a big box, right? So sites of care in the network design is extremely important. And how a network is, the architecture of a network is extremely important. So that's what we've built, right? We've built a clinically integrated system that I can go site of care. I could sit down with any employer and walk you through exactly the best site of care for your associates to receive their care. When we talk about value, we define it as great outcomes that are cost effective. Great outcomes that are cost effective, right? So that's what we've built. That's the design of the Ascension network here. And we go from Racine south all the way up to Fox Valley in the Appleton market. Where do we sit today? So we created this network, and this gets to Lisa and Rivka's comments. We built this network. We knew we had value. For 3 years, I would meet with carriers. I would meet with brokers, right? We knew we had the data within Ascension. We knew we had the value. We couldn't get anyone to really listen and want to do anything. We'd have meetings, and we'd put out ideas, and we'd say, we can help you. We can help your associates. We can help you as employers. We did not have the platform to be able to do that as Ascension Wisconsin. And so we built it. We created it. We wanted to partner, very intentionally partner. And it was mentioned today, that partnership with the employer, the carrier, and provider is critical. It needs to be very intimate. It needs to be personalized, right? And if you can create that, then you can actually drive value, right? And I can sit and I know, right? Healthcare might not be always trusted. Understand that. So here Ascension creates it, trying to tell our story, get our story out there. Listen to us, right? But we're sitting down with the carriers at that time. And then the carriers are trying to take our message back to the purchaser. And I'm not sure that message is coming through very clear. Until one day, through the Business Healthcare Group, they say, we're taking a different path. Now, we had many meetings, and they knew exactly what Ascension was building. We said, okay, third party, we're not going to just say, we'll take Ascension Wisconsin's word for it. You shouldn't. We're going to do our own assessment and evaluation from a market standpoint. And that's exactly what Jeff and the team and the board did. And they did it in partnership with the Centivo team. And they came back and assessed Ascension Wisconsin and other networks across the state and said, that's value. A third-party assessment, not me telling you. The only thing I did was listen to what the purchasers of healthcare wanted and needed, and that was to create greater value in this community for what we were building here. And so we did that. And then the rest of the story really is Business Healthcare Group and Centivo coming in, independent of Ascension, and saying, is what Bernie's saying true? Did we build what we say we would build? And is there value there? And you're going to hear from Dave. Dave's going to come up, so I'm not going to sit here and advertise that. But that's exactly what has taken place, to the point in time that 90% of our primary care physicians are in the high-value network. We got 200 providers for our primary care physicians that sit in that today. And so we're very focused on that. And this is how we do it, right? So, as I said, we built sites of care that were geographically accessible, because access is important. We focused on the site of care. You'll hear people say, unit cost isn't important. I say it is important. You have to know what your unit costs are. You also need to know continuity of care, right? So using the Centivo BHCG example, right? Staying within that high performance network is key, right? So if you want to get the ultimate value, you need to pay attention to that. You need to make sure that's happening. But don't be fooled, and don't let anyone say that unit cost is not important. Unit cost is important in everything we purchase. It is important. It's got to be tied to great outcomes, which ultimately creates great value for you as a purchaser, right? And so that's an important component. So we built that sites of care unit cost, and then we work very closely with the Centivo team around our high performance network. And so we've created the forum, we've created the platform where the payer, the carrier, the employer, and the provider, every month, every single month, we come together and we look at performance of the network, overall performance. And so the provider has a voice at the table, the carrier has a voice at the table, and the employer has a voice at the table. And as Ascension Wisconsin, I want to hear from the employer, and I want to hear from the carrier on how we can continue to improve value back to you. That's the only way it works. That's the only way it works. And so that's how we're positioned and move that forward. I want to leave you with a story, because I think it's a powerful story. And I think, when you hear a story, sort of proof is in the outcomes. So this is a patient experience story about a Ascension Wisconsin patient who is an employee of a large Wisconsin employer that offers Centivo to their employees. And this patient, one of your employees, your members, basically has told us that she's a lifetime Centivo member. I mean, this is really played out through a experience. So they had a number of hospital visits in a year, required to see their Ascension primary care doctor multiple times. Those visits resulted in a referral to a high-performing oncologist. The diagnosis of treatable prostate cancer and treatment was put in place. That patient, through the management of being connected to that primary care physician, we talk a lot about navigation in healthcare and how important it is. And every patient needs an advocate, because at times it is complex, right? And so this model of connecting with a high-performing primary care physician to help that patient navigate to get to the right specialist, the right sites of care for the right treatment, played out with this one. This patient has reduced his blood pressure, his cholesterol. He's lost 40 pounds. He is happy with his outcome. And the key is, so all that happened through this high-performing network, and the cost of care was positively impacted as well. So this is one individual story. There's many of those that are happening every day. We're here as a partner with all of you. We're here as a partner with the Business Healthcare Group. We believe in the model. We believe in what they're doing from Centivo. We think it's positively disruptive. Positively disruptive. And I think that term positively, right, when you think of all of you and what you want, that's the important thing. It's not negatively disruptive, it's positively disruptive. And it aligns with our point of view from our standpoint as a not-for-profit health system in this community. That's our job, right? That we're supposed to deliver value back to all of you. So thank you.
Things that were said. How about this one? Oh, much better. All right. So I'm going to pick up on a couple of things were said, and particularly something that sort of bookended those comments. You know, Bernie just talked about positive disruption. Todd really started out with a message that also had that question of positive disruption. What do you do as an employer? What do you do as a health system when you know the current system isn't working? And employers in particular over the years have always worried about disruption. It's always been a bad term. The reality is if you've got a broken system and you don't disrupt it, what do you have? A broken system. So that whole question of how do we create the positive disruption is important. You heard it from all four speakers. You know, Todd talked about the fact that we need to do things progressively as an employer. We need to make change. We need to facilitate the change. That's part of the mission of being a great employer. Rivka talked about the fact that you've got a major employer out there saying it's not good enough just to be a purchaser of healthcare for our people. We need to go farther. And we've actually created an entity that goes in and is changing the healthcare space by making strategic investments and looking at things that are different and trying things and looking at different pilot programs and different kinds of opportunities to change. And Lisa gave you a whole lot of numbers about how the system has both opportunities and challenges. And if you weren't a little bit scared at looking at some of those numbers that Lisa put up there, well, you probably weren't paying attention, because if we don't fix it now, we've got a bunch of embedded problems that are really going to come to the fore as we look at where the cost picture is and the embedded cost in healthcare. And so we have to think about changing it. And as you think about changing it, it's got to be a part of how do we really deliver and consume healthcare in a very different way. You know, if we can move away from some really labor-intensive healthcare sites where we can't get enough people to deliver the care and they're really expensive, and we can move to other sites and we can frankly keep people healthier, that's going to help the system. And Bernie talked about the fact that the health systems are listening to us as employers. It's no longer this barrier between employers and health systems. It's no longer, you know, somebody being in the middle, and it's often been the health plan administrator who's been in the middle, who's sort of served as the barrier between that direct flow of conversation. And this marketplace has been, from my perspective, a hallmark of one where the employers talk much more directly to the health plan, and the health plans don't get in the way. And with that as a theme, I'm not going to get in the way anymore. I'm going to bring our forum back up and have a little bit of a panel discussion and ask them some questions as we go. So if I can have everybody come back up, and hopefully between you know, the various mics that are up here and the various mics people are wearing, we'll be able to hear everybody. I'm going to start with what has been sort of a fundamental question in healthcare and healthcare in terms of change, which has been historically the fact that healthcare moves slowly. Change in healthcare has been tough. But we just went through a pandemic and we saw that that doesn't have to be the case. So I'm going to ask the panelists for each of their sort of perceptions on the whole question of timelines. How fast can we change? What should we expect? Is this something that we can move the needle in 6 months, in 2 years? Do we have to wait 5 years? How fast can we really change from the perspective of each of you, bringing kind of your own perspective and the groups you represent? I'll go ahead and start with Todd and get his thoughts.
Doesn't necessarily have an exact answer to that question. I think that's really challenging. I don't know that I do know it. To, like, many of our companies are undertaking transformation of our business models and have a vision for where we need to get, and oftentimes anticipate like how quickly we think we can get there, but we don't get there by waiting for it to happen. We take steps and we test, learn, and modify our approach. And I think that's what we have to do as employers in the healthcare space. We have to be bold. We have to not wait for something to be transformative, in that truest sense of what the outcome we absolutely want to get to, but we need to take steps. We need to learn from them, and we need to partner to adjust. And, Centivo is not the first value model Northwestern Mutual introduced, but we knew at the time, best available solution, but it outlived its kind of utility to us and wasn't going to get us where we really believe transformation is. And we have to then be ready to use those learnings and modify and partner to get to that transformative state.
I think this works, yes. I'll build on what Todd said. I think it is very easy to wait a long time to see any change. And my background most recently is coming from CMS, where I led all of the population health models at the Center for Medicare and Medicaid Innovation, which was created by the ACA to test innovative payment models and try to transform healthcare delivery. That slide with the savings versus the costs, that's my work. So you can see our success was middling at best. And we, left our nose to the grindstone for 10 years, really trying to transform it. On the employer side, it is both easier and harder to make change, at least from my perspective. Harder. JP Morgan Chase is a bureaucracy that parallels in some ways, challenges the federal government and how complex it is. And there's a lot of risk aversion, especially in the financial sector, where everything is a question of risk and risk mitigation. And so making change as an employer in healthcare involves assuming a certain level of business risk, whether it's making an investment that doesn't succeed or trying a new healthcare product that doesn't work and then having to tell your employees, actually, we've made a mistake and we're backing off. And I think the prospect of those things happening is very scary, especially for large employers. And when my team and I had a retreat earlier this year and we were talking about how to approach our pilot strategy, I said we should keep two things as our North Stars. The first is identifying where the ground is soft, because there is always a place where the ground is soft for change. And whether it's, to Lisa's point, the pandemic and its introduction of, or its acceleration of telemedicine as a really viable channel for healthcare delivery as a great example, or others, which is the just increasing market trend pushing us to focus on affordability, which is part of the impetus for our investment in Centivo. We should be focusing on places where the ground is soft and using those opportunities to really push for change faster than we would otherwise. Two is opportunism, which is a strange thing to promote. But as a large employer with 285,000 employees, again, it's easy to wait around because it's very hard to make change for 300,000 people. And it's really important for us to be opportunistic. And so again, from my perspective, you have Centivo, we have Centivo in a market that is relevant to JPMC. We have a market of concentration where Centivo is playing. Why wouldn't we test it there and see if it works? And if it works, we will scale it, rather than saying, let's wait until Centivo is in all 7 markets of concentration or everywhere across the country where all of our employees are located. That is the easy approach, is to wait and see, but it's not going to be successful in the long run.
So one of the other things that the pandemic made me optimistic about, if I'm looking at the provider side of the healthcare world, is that, healthcare is one of the slowest moving parts of our economy, but COVID proved that providers could do big things fast. And the fast is really important because, you know, what they hadn't largely demonstrated was agility and the ability to pivot. And I mean, and boy, did they do it, not just the telemedicine, but, you know, standing up whole different units, staffing in different ways, you know, being there for the community. I mean, rolling, the vaccines were essentially handed to providers and you go forth and find ways to, you know, immunize your communities. I mean, those are big changes. It has energized the industry. And, you know, you talk to people who work in health systems like, man, I hope we keep some of that shift in culture that we had where we didn't have to run every decision 10 layers up and can make big moves and can apply it to things like value. But I think, you know, if I'm in your shoes and I'm looking at, you know, who's a good provider partner, you know, right now the problem with most health systems is they're stuck in the middle. They agree that they would love if the world moved toward value, but most of their business is still in fee for service. And it's time to like say, which direction am I going? You can have a valid path forward in either one. Take the nation's largest for-profit health system, HCA. They're very comfortable being what I would call a subcontractor. Someone else is going to build that platform. They're going to run very, very efficient hospitals and other care sites, and they make a mint of money off of doing that. But if you actually want to be that platform, be the value partner, you have to decide that's the business model I'm going for. And I hate this phrase. You've probably heard it described, you know, when you're talking about transformation and accountable care, a foot in two canoes or a foot in two boats. We're looking for things that help us in either boat and stay balanced. I actually think for most providers right now, the time is to like decide which canoe do I want to be in and find the path to row. And it's going to be hard if you choose the value canoe. I work with a health system in the Pacific Northwest who has said, you know what, I have to go to my board and say the next 3 to 5 years might be rougher than they would have been otherwise because we believe we need to push the market in this direction because if we don't push, things are just going to stay the same. So I hope that, you know, as you're talking with Bernie and others, you're able to find the pushers.
Yeah, Lisa's, I think pre-pandemic, I think I would agree with what Lisa said that health systems were not very agile, but the response to the pandemic in so many ways taught health systems that we can move a lot faster than we have historically, whether it's around value. I mean, just going back to the pandemic, whether it's setting up testing centers, our whole procurement had to change when we were trying to get PPE access to that. You know, that has definitely taught health systems that we can iterate new directions at a much faster pace. And so, going back to the comment around the virtual visits, in the heat of the pandemic, we had 900 providers. Maybe 1% to 2% of those were trained on the platform. We trained them within a couple weeks, right, on how to use the virtual platform. During the pandemic, we were driving about 70% of our visits through the virtual platform. So it can be done. And I see the change and what we're trying to do in partnership with BHCG and Centivo is we are in both worlds right now. There's no doubt about it. And it's very difficult to play in both of those worlds. It just is as a healthcare delivery system. But from our point of view and our perspective here in this community, right, it's finding partnerships to create that value. And we'll be as agile as we need to be if we have a willing partner on the other side. And that's very important to hear from health systems. I don't have a lot of extra resources. I want to put my resources towards solutions that are going to make a difference. And so I have to have a partner because I don't have time. I don't have excess resources. So I have to make sure that what we're going to do together is going to be, number one, we're going to be together as a partner and we're going to agree on that value proposition. And if I can get that type of commitment from a partner, like we're all in and we'll move as fast as our partner can move.
You know, Rivka, you let the cat out of the bag saying, you know, you'd been in the CMS world. You know, kind of a foundational question, why do employers have to do this? Medicare, CMS, the federal government's 800-pound gorilla. They can mandate prices. They can decide what's going to be covered, not. Why shouldn't we have them fix the problem? Why should we as employers have to fix the problem?
I mean, the easy answer to that is that we don't have a single payer system. So, hey, if you want one, lobby your members of Congress. Last I checked, it was not particularly popular. So that's the easy answer. I think the level of nuance beyond that is that the government is designing a system for Medicare and Medicaid beneficiaries. Two different categories, but there are some similarities there. There are a lot of differences from the employed population. And so a system that revolves around people with multiple chronic conditions, where a majority of people in a payment system, right, like a majority of Medicare beneficiaries have at least one chronic condition, probably two at this point, is a much different reality from the ESI population, which ranges from your 22-year-old post-college, not really interested in ever going to a doctor's office if they can avoid it, to your, 65. And I would argue even that the 50 to 65 population of employees has gotten short shrift and is now starting to enter the mainstream as new vendors are offering things like menopause support, for example, which is a burgeoning area that has historically essentially been ignored in the ESI world. So just two different categories of populations. That's the easy answer. The hard answer, and this is like more complexity than we have time to get into, is there is a strongly held belief that is inaccurate, but again, strongly held, that the system sort of cross-subsidizes itself, right? That Medicare and Medicaid pay less for healthcare, and as a result, providers, carriers, and the like charge employers and commercially insured lives more for their healthcare. There is some truth to that when you look at the two graphs on a slide, right? Like Medicare does pay less as a percentage of cost, commercial does pay more. The actual dependencies there are much more complicated, and a lot of economists have done a lot of work to show that it's not true, but again, strongly held belief. And so when you take that reality where Medicare and Medicaid are not covering a typical hospital or health system's costs with enough room for margin, and the commercially insured lives have a lot more cash to burn because they're privately held, you have a system that looks a lot like what we have today. The last thing I would say is, again, this is our cross to bear as employers. It's not necessarily something we would have signed up for if we had a choice, but we don't have a choice for the most part. And as a result, we, the employer community, have really leaned in and said, how can we make this better? And there has been incredible progress there. The progress comes in fits and starts. It's not linear. There are times where it feels like we're spending a lot and we're not getting value for it. But I would say that if you look at a company like Centevo, which is focused entirely on the employer sector and is really trying to drive value in a way that is unique, not just from the ACO models of the past 10 years, but unique in some ways from the Kaiser model, which is, wholly owned, wholly integrated, and it is a value play, but it is a different kind of value play. It's refreshing and I think encouraging to see somebody come in down the middle and say, there is a way to do this that offers your employees choice, which is a key principle that employers believe their employees want, that again is somewhat true in some cases, offers choice, and puts the keys in employees' hands to say, what do I want to buy here? And, I was talking to somebody last night who, from Sendix, who is working with Centevo, who said one key priority that we have made in our communication to employees around this product, which is not intuitive necessarily, especially in a world where they've been trained to believe that they want choice and that they should pay for it, is to say, we are actually all in this together, right? We're not in single payer healthcare land, but we are a collective where everybody's healthcare choices affect what everybody else pays for healthcare and what they get for it. And so if we think of ourselves as a collective with collective buying power and collective agency, we will start to realize that each person's choices around what they buy inform how we all get healthcare and whether we get value. And with that, they have seen a lot of movement to the Centevo product because of the value that it offers.
Pick up on a couple of those thoughts. And Todd, you represent an employer which is clearly seen as a very good employer in the community, one who actually cares about its people. When we look at making these kind of changes, I think we often think about the fact that there's a bit of a risk that goes along with it. You were good enough to speak at the BHG annual meeting, and there was a phrase that you used that I thought was incredibly telling. When asked about taking the risk, you said, it's, for us, it's not a risk, it's a responsibility. Which I thought was incredibly impactful, and one of the things that it really raises, as we sort of asked you to expound on that, is what do you think employers can and should do when it comes to stepping much more into this whole healthcare decision-making, the healthcare role for your people?
Thanks, Dave. Bernie made the case for my statement in terms of risk versus responsibility. When I think about that Ascension patient that you spoke of, that's exactly why we believe this is our responsibility, and we're doing a lot of that, within the walls of Northwestern Mutual to bring to light the storytelling and the examples where people are like life-changing care, and it's profound, and that I think we're all looking for purpose in our work, and that's my purpose. When I hear about those members, those family members that are being impacted by the transformation that we're undertaking, that's why we are more than happy to hear some of the noise from our members and to help them understand where we're going with this. We've done a number of things over the last 10 years at Northwestern Mutual to instruct and to drive towards value. We do have on-site medical centers. They're a really important part of our health system for Northwestern Mutual employees. We manage that very closely. We have a wonderful partnership, and it's driven off of a shared vision around value and quality and care. And it's there's no ulterior incentives from the that are at play in terms of putting the patient at the center of that relationship. I think the other thing we all can do as employers in southeastern Wisconsin is partner and look for continued solutions to advance quality and cost efficiency and care in our community. And I don't know exactly what those solutions will be a year from now or 2 years from now, but I know that they'll continue to surface, and we have to support them and make sure that they're viable as they do kind of present themselves.
So let me pick up on that, Lisa. There's been a lot of words about collaboration and working together, and you see health systems across the country in various marketplaces. I'm sure the words collaboration and shared vision and all those things come up all the time. What things do you need to see to say this is real, this is where collaboration actually happens, and when do you say those are just nice words, but end of the day it's really just BS?
Well, one thing just hit me, having been a part of other forums like this, it says a lot about how committed a health system partner is when you got the CEO coming to meet with all of you. There's a lot of systems that would have sent the associate VP for network contracting to come to a forum like this. That tells you a system's committed. I'd ask them, how are they doing with their own employees? Most health systems are the largest employer or one of the largest employers in their communities. How are they managing their benefits, their spend, and keeping them healthy? Do they know the nuances? We've talked a little bit about, the work that Medicare has done and how that was a catalyst to help health systems and doctors start thinking about value. But, the things I need to do to deliver value in the senior population, largely focused around management of chronic disease, don't fully overlap with what your problems are. Do they understand and have solutions for how they're going to manage high cost events, which are the things that really spike your spend, the patient with cancer, someone who blows out their back, the baby that ends up in the NICU, the long list, all of the high cost pharmaceuticals, how many people do you have in your workforce that are on Humira now? Do they have solutions for those kinds of pain points? And the last thing I would add is, do they recognize the faults in their own system? One of the things that you said, Bernie, that stuck in my head was that 95% of our primary care physicians are part of our high value network. It ain't 100. Every health system has a lot of good doctors and some that are not so great, but they all want you to take the whole thing lock, stock, and barrel rather than looking critically, where are the places where we need to improve? Where are we not strong? Where should we partner? You know, are they taking that lens to themselves around performance and bringing you the best of the best?
And on that topic, Bernie, we asked you to do some hard things, like Lisa just talked about. We said, you know, in this model, some of your doctors are not going to be considered high performing, and they're not going to be available to people to be sort of that quarterback for care that you'd like them to be. We'll work with you to make those people better, but out of the gate, we're going to ask you to, you know, to make some hard decisions and to, you know, work with us to you know, create a network solution that you know, doesn't have all of your players in it. And I give Ascension and I give most of the health systems in this community credit, who stepped up and said, you know, that is something that we understand and something that we can accommodate, not necessarily something we love, but something that is, you know, we understand the fundamental role as long as you're working with us to go through the continuous improvement cycle. So I'm going to give you the chance now to turn around and say, okay, so you've done some hard lifting. What 2 or 3 things do you want the employer community to be doing to help you deliver your best care? And what 2 or 3 things would you like them to stop doing?
Let's start with, you know, what would I ask of the employer community? And I think it's, you know, it's played out here, at least for those employers that have picked what I would call as a value platform, right? Those that have picked a value platform is the realization that you have to have that relationship and partnership that can really drive value, and I would say transparently. You know, there's a lot of talk around transparency, right? And I think that that's key to all of this. Transparency along each component of it as you're trying to build value for your companies, you know, through your medical benefits. So that I would just encourage you, if you're not doing that, to like start doing that and understand how you create a platform to actually deliver that. Okay, we've heard a lot about that today, so that would be number one. That's the to do, right? That's what you asked me the to do. Now you want me to tell them what to stop?
What they should stop doing? Yeah.
Yeah. Be aware. Again, this goes back to just really understanding how it all comes together. I'll use an example. I'm not going to mention the carrier, but if you really want to create value, then you as an employer need to become much more aware. So what I'd say is stop doing is, if you are not intimately involved and really understand how value is created, stop that position. You've got to get in the game as an employer and really understand. If you really want to create value, then you've got to stop sitting on the sideline. I think it's already been said. I think, Rivka, you said it.
I'm going to build on what you said.
You got to stop sitting on the sideline and really get intentional about really understanding what that means if you really say you want to create value. On the physician side of things, we're a learning organization. We know we're not perfect. We're not perfect today. We've got a lot of things we need to continue to work on in this idea of value. We're committed to do that. And so if I have physicians that are not in the high performance network, that's okay. Internally, we have a process of physicians that meet with physicians and coach them and tell them, like, you want to be in this value network. And if you want to continue to be part of Ascension Wisconsin, you want to work towards getting into that value network. So it's okay to have those courageous conversations. If we put good data in front of physicians, they want to be in the high performing network. And a lot of times it's just, they don't have the information. And so you have to have that platform, you have to have the data, you have to be willing, and we're willing. And we've done that. And we've been doing that for years. And that's why we have so many of our physicians considered in that high performance network, is because our physicians who are leading Many of our medical groups are willing to have those courageous conversations and put the information in front of them.
I want to build on Bernie's point about courageous conversations. We at Morgan Health are privileged to have a team of data scientists who are doing the sort of exploration that I think is paramount to any of these efforts. We are trying to understand the status quo, and that is everything from a health equity analysis to try to understand where disparities lie in our population, a health equity analysis of the national population using publicly available data, which is on our website if you are curious to see a snapshot of employer-sponsored healthcare outcomes today. Spoiler, they're not good. They're really quite bad, in fact. And just one statistic that I'll share, nearly 6% of employer-sponsored insurance members are food insecure. They don't know where their next meal is coming from. That is a staggering statistic for people who are not just employed, but get insurance through an employer. So we are doing a lot of examination of just what the status quo is and what problems we have to solve. But beyond that, to Bernie's point, we are looking at the data on healthcare utilization of our employees to try to understand and then inform and educate our internal stakeholders about what a change would and could look like and what it would actually break. So I don't know about you, I imagine some of this is true for some of you, but as an employer, you are contending with internal stakeholders' general resistance to change. Like, this is the way it's always been, let's not change it. That one's obvious. You are contending with a strongly held belief that your employees want choice. And that is something I hear every single day at my job. And it's something that I both accept because it's true for some people and also feel strongly about combating because it is not true for everybody. And we need to, again, take opportunities where the ground is soft to say, can we offer something different for people who want something different, and just see, will people buy it? Will people come? So one thing we've been doing, I think this gets right to Bernie's point about the courageous conversations, is actually looking at where our employees go for healthcare. Because again, there's this belief everybody wants to see everybody. Well, in our markets of concentration, that is not true. And there is actually quite a lot of alignment between some of the high value networks that exist, Centivos and others, and our current traffic patterns. So why would we not take advantage of that fact and say there's already groundswell to do this? Let's formalize it by cutting some of the low value providers out of the network and probably saving everybody money in the interim. So that's just an example. And of course, once you look at those data, you have to have the conversations. And we've had conversations with our internal stakeholders on the benefits side to say, look, these are the trends we're seeing. It would be silly to ignore them. And also with Centivo to say, will you do what you've done in Wisconsin and other markets? And I recognize there is so much that goes into what you all have built here that is probably hard to replicate. But to subset a network takes incredible courage. And it also is a catalyst for change. And so it's something we're really focused on at Morgan.
And I'm just going to quick repeat that for those who are on the virtual. We don't usually get a panel this great all in one place at one time, so we're going to go for an extra 10, 15 minutes. If you need to step out, then we realize we're at the end of our scheduled time. But for anybody who wants to stick around, we will keep going. I'm going to ask for any questions from the group here to see if anybody has things they'd like to touch on that either we haven't talked about or follow up on. And if not, I have a couple additional follow-ups because there were so many sort of meaty items that came out of that I think they'd be really interesting to hear. But let me see if there's questions from the group here in the room.
Hi. What do you see as the future of kind of the return of the house call, in-home care? Curious your perspective on that.
I can chime in as investor if you want to chime in.
Yeah. I mean, I think that's a perfect example of something that the pandemic accelerated. Whether it is, and I think we need to think about it as a spectrum from I can text my doc and ask a simple question all the way, if you've heard of something called hospital at home, where you can get, for certain conditions, full on acute care in your home. It's safe, it's high quality, and patients love it. I think that is something that it's another one of the things I'd be looking at if you're talking to a provider partner. And it's part of a larger category of how are you moving access and care closer to where my employees and your patients and consumers live their lives day to day. I think we're going to see it continue to explode. The question becomes, who controls it? Because if I'm a big insurance company, I want to have that in my portfolio. Wow, I can completely circumvent those greedy, expensive hospitals and specialists, and I can own the home care. I mean, that can be fine. I'm all for everyone having more access to those kinds of things. But where it breaks down is who's going to coordinate all of this and create a truly integrated system of care. And if I had to say who's best positioned to do that, I bet with health systems who are moving toward that platform vision.
Let me add one thing to that, because there are health systems across the country moving towards that. This is not traditional home health.
Yes.
This is innovating care in the home, hospital to home. The payment system has not caught up with where the innovation needs to go. So that's something that needs to continue to be advocated for, so you can really innovate and create different care models in the home setting. I think health systems, a lot of health systems would like to go there from a home-based care, hospital to home. The payment system hasn't yet caught up to that.
Other questions from the group?
Bernie, this one's kind of for you. So as we move more and more towards that value-driven care, and you're seeing that come across throughout your entire provider group, how has that helped or how hurt the attraction and retention of providers within your own system and getting people on board and adopting this as their new methodology?
I would say overall, we've been doing this for some time at various degrees. And overall, as a network, it's sort of part of the culture within our health system is to, have a network of primary care physicians. Because in the past, it's been different levels of sort of value creation opportunities. We've been working with various carriers for, years and years. So I would say there's that acceptance in this community. I think there's, for some time now, before I even landed here, there was this eye towards really value creation on healthcare delivery. I think it's just being amped up more and more. So that acceptance is there. We've been sharing the data that we could get our hands on, back that usually came in from the carriers, right? So, this platform gives us a little bit more information coming in from the employer. So if we can put those two together, I think we can have a greater impact on that overall value. But yeah, I think overall our provider community understands it. They understand, at least in this community, it's important and accept it.
Other questions? Yeah, so I think, the question is really, when you look at this marketplace, the employers of BHG did something truly unique, at least in my perspective. And I've seen, groups like this across the country. This group went in and said, we are going to do the probably most sophisticated, most, both resource and financial resource and time-intensive kind of analysis to look at a big data study on where the performance of physicians in the state are, and particularly primary care physicians in the state. It is something that is interesting that it was the employers that did this, not a health plan, not an academic group. It was the employers that said, we need to have this data, we need to understand it, and we need to take it to the health systems and talk about how this is done. The physician value study showed some really interesting results. I know a number of you have seen some of our past presentations around that. The headline numbers were, if you look at the performance of the primary care physicians who are in the top half from a cost efficiency standpoint, and we could either have our patients seen by that group or have the group of providers in the bottom half move towards the top half performance, we could save 40% of the cost of care of the episodes of care managed by PCPs. A pretty profound number. It was interesting, again, that it was the employer group that was driving that. So I think we get to a fundamental question. And you've seen it in other parts of our society. Education went through this, where all of a sudden we decided we were going to do testing that was standardized across the country, and a lot of the professionals in education said this is really bad. It's people who don't know education who are asking for it. Well, in this case, the health systems could come back and say, well, I'm going to fight your data analytics. I'm going to really pick at you as to why the study isn't good. I give Bernie and a number of his colleagues in this marketplace credit to say that's not what they did. They didn't spend all their time throwing stones at the train. They got on the train. But it does raise the question of we as employers, should we be doing these things? Is it of real value? Is it the right role for employers to play? I'm going to ask Todd and Rivka to sort of comment on that from the employer side, and then probably have Bernie respond a little to that.
I mentioned earlier that the Centivo solution and the work that we're doing with the Business Healthcare Group isn't our first crack at trying to direct our employees to value. Our first attempt, while as a first step into this had value, there was a recognition over time that methodology and evaluation of physicians was limited, and the carrier was unwilling to take steps to really drive value in that and bring transparency to us as employers, really where's the value in healthcare in our community. And that's why I think the value is in us as employers being at the center of that and driving that and really being able to have confidence in the evaluation and the methodology, and then to be able to work with the health systems to say, how do we change this when we need to?
Yeah, Todd, I think I agree with you. I will say I would stop short of saying that employers have to do this. Most employers are focused elsewhere and are not going to spend the time and resources to do an examination like this. And I would also note, Haven built everything from scratch, spent a lot of time and money, and then nothing came to fruition. A few things came to fruition. And as a result, we at Morgan Health have a bias toward buying rather than building. The good news is that there are companies that are focused on doing this. Centivo is one example, and they're focused, for a clear reason. There's another company called Embold Health, which we've also invested in, which is a quality data company, and they're doing data analytics to try to understand comparative quality in the provider population. We don't have to do that as an employer, but we need to be paying attention to the results, and we need to be willing to act on the results when they come out. Because as the data become more available and as more companies lean into the transparency in the consumerism space, we as employers have both the responsibility and the opportunity to capitalize on those data to drive behavior change.
From a health system standpoint, I think, our position has always been, if I go back to 2016, I wanted to build something of value. I can sit there and tell you I've created something of value. It's affirmative when it's a third party that comes in with their data independent of what the health system's saying or what my marketing might say or a billboard that I might put out there to try to say, I'm the best value in the community. I like it. I think it's transparency to the highest degree. Certainly, I want to understand the data and the source of the data, but we're not going to refute the information once we have an understanding where it comes from. I think it just affirms. And when it's done by a third party, I think it's more believable. It's more trusted. So that's our position.
The quick thing that I would say is just recognize what's special and unique about what you've got here. We see other employer collaboratives across the country, to have something like BHCG that takes the initiative, the effort, the resources to pull together all of that data so that you've got something that gives you real transparency into the market, that brings together the best partners, whether it's on the employer side, Centivo on the insurance side, Ascension and others on the provider side, Morgan on the innovation side. I mean, there is momentum here that you do not feel in these other types of convenings in other places. it's a special thing.
So I'd love to keep this panel together for the next 2 or 3 hours, but recognizing that's probably impractical. Join me in thanking the panel, and I appreciate all of your time today. And, you know, we'll be continuing to delivering value series symposiums over the next number of months here because there is so much happening in healthcare. But appreciate your time today and definitely appreciate the panel's time.
It was fun. Thanks so much. I love your fun. Conversation. Yeah. We talk about crucial conversations. Yeah. Well, hopefully our paths cross again. If we can ever help you guys at Ascension, let us know. Yeah, let me get you my card. Yeah. So my partner and I don't know if you've ever met Chaz Rhodes, we were both advisory board execs and jumped ship when Optum acquired the company. We were leading all of the research and strategy work for CEOs and didn't think that we would be viewed as impartial if we were getting our paycheck from those guys. So, yeah, and we launched just 5 years ago and work with systems both in, you know, speaking and convenings is, you know, part of what we do, but we also work with a handful of systems as members advising on strategy. Yeah. Oh, thanks. Well, and we love bringing that stuff with, you know, more detail and more, you know,